The first one in the eye complication is diabetic retinopathy. Diabetic retinopathy, it is mainly two stages, the non-proliferative and the proliferative diabetic retinopathy. The non-proliferative is usually comes early, and usually in some studies it will be preceded by, before the diagnosis of diabetes, by mainly around 5 years. The non-proliferative diabetic complication and diabetic retinopathy, it's mainly in the earliest stage of retinal involvement. It will be a change in the microorganism with some dot hemorrhage and exudate and retinal edema. This retinal capillaries leak of lipids and red cells will cause some retinal ischemia and deposit. This can lead to the macular, clinically significant macular edema, which is most commonly presented to the patient as decreased visual, or they will see some haziness in their vision, and it might lead to visual impairment in diabetic type 2. On the other hand, proliferative retinopathy is growth of the new capillaries with fibrosis of the tissue and the retina into the vitreous chamber, and this will be more common in diabetic type 1 and prior to proliferation of new capillaries and pre-proliferative phase that will lead to ischemia and the cotton wall spots. You remember, this is part that will be repeated in a lot of your exams, that you will see cotton wall spots, which is mainly infarcted small areas in the retina. And this will come a lot in your exams, and this is mainly related to the proliferative type of retinopathy. I just put some examples of pictures. As you see, this is non-proliferative diabetic retinopathy. We said there is some hemorrhage, some aneurysm in the vessels, and there will be some hard exudate. And this is another true picture of the fundus. And you can see, as you said, some exudate, some hemorrhage, and some proliferation of the vessels. On the other hand, the proliferative one, as you can see, there is a lot of abnormal small vessels that will develop in the retina. And this will lead to fibrosis, and sometimes, as we said, it will lead to ischemia, the cotton wall picture. As I said before, there is a lot of studies which will show that the prevalence of retinopathy, sometimes it can precede the diagnosis of diabetes by sometimes up to 5 years. And this is proven by a well-done studies that was published in Diabetic Care in 1992 by Hertz, that shows in people that in Wisconsin in blue line and the people in Australia in the red line, it showed that retinopathy have been there in the eyes of 10 to 20% of the diabetic patient, and some of them it will be there around 5 years before the diagnosis of diabetes. The incidence of diabetic retinopathy over time also will increase. So it's one of the most common complications to develop with time. And one of the late complications that will appear, but unfortunately, when it happens, is most of the time it's non-preventable and difficult to be treated, and it will lead to a very difficult complication on the patient life, which is blindness. In a very well, we are going to speak about this study again and again in most of our complication. A study was published by Al-Wakil in the Annals of Saudi Medicine in 2008 that shows that background retinopathy will appear in around 11% of the 11% of the population, and it will take around 14 years in mean between the time of diagnosis and the complication of your patient. Therefore, this is something to keep in mind whenever you are seeing a patient and he is diagnosed since more than 10 years. This is more to emphasize that he has to check his eye, because this is the time that you can prevent further damage and retinopathy of your patient. And in another study also have been shown that diabetic retinopathy published in Saudi, it will occur in most of the patients between 10 to 15 years of the diagnosis of diabetes. Treatment of diabetic retinopathy, it's mainly the photocoagulation, especially for the severe non-proliferative retinopathy. And vertectomy for severe proliferative diabetic retinopathy with a vitreous hemorrhage and traction of the involvement macula is the treatment for the proliferative part. So remember, the photocoagulation is mainly for non-proliferative, and the vitrectomy with vitreous for the vitreous hemorrhage is your way to treat proliferative diabetic retinopathy. There is no contraindication, and this is, I want to emphasize again and again, there is no contraindication of using aspirin in patients with proliferative retinopathy. Keep this in mind. Yes, there might be hemorrhage, but there is a misconception, misbehavior of not using aspirin in patients who have proliferative retinopathy. And this is to confirm, yes, you can use aspirin in proliferative retinopathy. Okay, so if we want to say few important lines about prevention of diabetic retinopathy, it's mainly going to happen, and we are going to say it again in every diabetic complication. It's mainly the good glycemic control, good blood pressure control, and smoking cessation. And there are many studies which will confirm if you have a diabetic control of a hemoglobin A1C of 7, you have much better decline in development of diabetic retinopathy. And as you can see in the graph, this is very clear. It's the relationship between the percentage of diabetic retinopathy that will occur compared to the hemoglobin A1C. As you can see, the percentage will be increased significantly as much as you move to hemoglobin A1C of 9 and 10. This will be significantly related to further damage and further diabetic retinopathy. Diabetes and cataract. There are mainly two types of diabetic cataract. One is the subcapsular cataract, which occur predominantly in type 1 and may come on fairly rapidly with a significant correlation with hyperglycemia and uncontrolled diabetes. And it have one of the significant pictures and phrases that can be describing this phenomena is the snow wolf appearance. And this is mainly, if you see this is in a question, this is mainly related to subcapsular cataract, and it's mainly related to diabetic retinopathy and mainly related to diabetic type 1. So if you see in any question, you see that this is diabetic type 1 who is having some kind of eye complaint, and they tell you that it shows snow wolf appearance. This is most likely a subcapsular cataract that you have to take care of. The second one is senile cataract, which is the presence of sclerosis changes in the lens nucleus, and it's the most common type of cataract found either in diabetic or non-diabetic adults, and tend to occur in younger diabetic patients, and particularly with poor glycemic control. The pathogenesis of it, it's mainly glycosylation of the lens and the sorbitol accumulation. The sorbitol accumulation in an insulin-dependent lens will lead to osmotic changes, and ultimately it will lead to fibrosis and cataract formation. So, let's say again, the main mechanism of pathogenesis of cataract is mainly sorbitol accumulation, which will lead to osmotic changes and fibrosis. Then it will lead to cataract formation. Glaucoma, it occurs around 6% of the diabetic patient, and this generally represents a usual therapy of open-angle disease. Close-angle glaucoma can result from neovascularization of the iris in diabetic persons, but relatively is uncommon, except after cataract extraction, which can accelerate new vessel growth, and then it can lead to a closed-angle glaucoma. So remember, glaucoma, it's mainly open-angle glaucoma, which is common to happen in diabetics, and it can be treated with a regular follow-up by the ophthalmologist. So ophthalmic examination, and this is what should be the schedule. In diabetic type 1, it's within 5 years after diagnosis, and then it should be done in a yearly basis. In diabetic type 2, the time of the diagnosis, and then in a yearly basis. In pregnancy, in pre-exciting diabetes, prior to conception, and during the first trimester, on the risk of development of progression of neuropathy. And you will follow up this diabetic gestational diabetes. You will have a close follow-up throughout pregnancy and 1 year postpartum. So the follow-up of diabetic retinopathy will stop after gestational diabetes 1 year after delivery.